Hello students, myself Dr. Sabitha Gokulraj, Associate Professor from the Department of Oral Medicine and Radiology, Vinayaka Mission Sankaracharya Dental College, would be presenting on the topic white lesions of the oral cavity. These would be the contents of my presentation. I would be giving you the various reasons why lesions appear white, with a classification and discussion of some of the lesions like leukoedema, Fordyce's granules, linea alba bacalis, leukoplakia, lichen planus, candidiasis, and oral submucous fibrosis. The learning outcomes would be to classify the white lesions and discuss in detail the clinical features and management of various white lesions by the end of my class. White lesion is a non-specific term used to describe any abnormal area of the mucosa that on clinical examination appears whiter than the surrounding tissues, and it may be slightly raised, roughened, and from the adjacent mucosa. There are various reasons why oral mucosa appears white. The probable reasons could be because of the increased thickness of the oral mucosa, degree of keratinization, depends on the amount of vascularity and the fibrous content in the connective tissue. Microbes, particularly the fungi, can produce whitish pseudomembranes consisting of sloughed epithelial cells, intra and extracellular accumulation of fluid in the epithelium. It could also be because of the necrosis of oral epithelium, which may occur when the oral mucosa is exposed to toxic chemicals. The image shows the oral epithelium stimulated to increased keratin, which is called hyperkeratosis. There may be an abnormal but benign thickening of stratum spinosum, which is called acanthosis. Moving on to the classification of white lesions of the oral mucosa. 1. Variations in the normal mucosa, which includes leukoedema, Fordyce's granules, linea alba bacalis. 2. Genetically linked with white keratotic lesions includes oral genodermatosis, white spongy nevus, hereditary benign epithelial dyskeratosis, and pachyonychia congenita. The third, post-inflammatory white lesions include traumatic keratosis, mechanical trauma, thermal burns, chemical burns, which includes aspirin burns and uremic stomatitis, radiation mucositis, reactive mucosal hyperplasias like stomatitis nicotina palatini. 4. White and red lesions due to infections, which includes syphilis, measles like Koplik spots, candidiasis, bacterial stomatitis. 5. The pre-malignant lesions, which includes the leukoplakia, lichenoid reaction, drug-induced graft versus host diseases, actinic keratosis, discoid lupus erythematosus, chronic hyperplastic candidiasis. 6. The pre-malignant conditions, which include lichen planus, oral submucous fibrosis, oral psoriasiform lesions, dyskeratosis congenita, and siderophonic dysphagia. It also includes syphilitic glossitis. 7. It includes all the other miscellaneous lesions. As we have learned the classification of white lesions, let us now try to understand the white lesions resulting from the variations in the structure and the appearance of the oral mucosa. The first variation is leukoedema, and in some individuals, the buccal mucosa retains its normal softness and flexibility, but exhibits a grayish white, slightly folded opalescent appearance, which is called leukoedema. Leukoedema is a common oral mucosal condition of unknown cause that represents a variation of the normal condition rather than a pathological change. Factors such as smoking, alcohol ingestion have been implicated, but none are proven causes. Males are twice more frequently affected than the females around the age group between 15 to 35 years. Leukoedema can be easily diagnosed clinically because of the white appearance greatly diminishes or disappears when the cheek is everted and stretched. The first image shows the diffuse white appearance of the buccal mucosa, and the second image shows whiteness disappearing when the cheek is stretched. The next, the linea alba, is a horizontal streak on the buccal mucosa at the level of the occlusal plane, extending from the commissure to the posterior teeth. Linea alba buccalis does not require any treatment, and the white streak may disappear spontaneously in some people. We'd like to discuss about the phodesis granule, which is a developmental anomaly. Keratinized external vermilion border of the lips are sometimes disfiguring and may require surgical treatment, otherwise no treatment is required. Next, let's move on to the white lesions with definite precancerous potential. Before we move on to the various white lesions, let us try to understand three terminologies. The first one, the premalignant lesion, which is defined as a morphologically altered tissue in which oral cancer is more likely to occur than in its apparently normal counterpart, which means that there is an area which is morphologically altered will have more potential to become malignant than its normal areas. The second definition, the premalignant condition, which is defined as a generalized state associated with a significant risk of cancer. It is not a localized area of alteration, but it's the generalized state which can lead to cancer. As per these definitions, it states that any premalignant lesion or a condition is definitely to convert itself into a malignancy, but it does not happen all the time, and some lesions or conditions remain the same without any malignant transformation. After long discussions, it was considered to use the term potentially malignant disorder, which means that the lesion or the condition has the potential to convert itself into a malignancy, but not that all lesions and conditions get converted into malignancy. Considering this, the WHO has come out with the definition of potential malignant disorder, which is defined as a group of disorders of varying etiologies, usually tobacco, characterized by mutagen-associated, spontaneous or hereditary alterations of or mutations in the genetic material of the epithelial cells, with or without clinical and histomorphological alterations that may lead to oral squamous cell carcinoma transformation. Let's move on to the first white lesion that we'll be discussing, leukoplakia. The word oral leukoplakias is derived from the word leuko meaning white and plakia meaning patch. Leukoplakia is defined by the WHO, the World Health Organization, as a white patch or a plaque that cannot be characterized clinically or pathologically as any other disease, and which is not associated with any other physical or chemical causative agent except the use of tobacco. The definition of leukoplakia is unusual, and that it makes from the diagnosis dependent not so much on the definable appearances as on the exclusion of other entities that appear as oral white plugs. Leukoplakia is by far the most common oral precancerous lesion, representing 85% of such lesions. When the outcome of a large number of leukoplakic lesions is reviewed, the frequency of the transformation into malignancy is greater than the risk associated with a normal or unaltered mucosa. Let's move on to the etiology of leukoplakia. Tobacco. The habit of tobacco smoking appears most closely associated with leukoplakia development, with more than 80% of the patient with leukoplakia being smokers. 2. Sanguinuria. Persons who use toothpaste or mouth rinses containing the herbal extract of sanguinuria may develop a true leukoplakia. This type of leukoplakia is usually located in the maxillary vestibule or in the alveolar mucosa of the maxilla. Third, ultraviolet radiation is accepted as a causative factor for leukoplakia of the lower lip vermilion. This is usually associated with actinic chelosis. Fourth, the microorganisms. Several microorganisms have been implicated in the cause of leukoplakia, like Treponema pallidum, Candida albicans, human papillomavirus, in particularly the subtypes of 16 and 18, which has been identified in some oral leukoplakias. Vitamin deficiency is also sometimes the causative agent for leukoplakia. Let's move on to the clinical features of leukoplakia. Locations where smokeless tobacco is frequently used, leukoplakia appears with a higher prevalence. Leukoplakia usually affects persons older than 40 years of age, and the prevalence increases rapidly with age, especially with the males. Approximately 70% of oral leukoplakias are found on the lip vermilion, the buccal mucosa, and the gingiva. Lesions on the tongue, lip vermilion, oral floor, however, account for more than 90% of those that show dysplasia or carcinomas. Early and mild lesions appear as slightly elevated gray or grayish-white plaques, which may appear somewhat translucent, fissured or wrinkled, and are typically soft and flat. Let's move on to the classification of leukoplakia, where according to the clinical description, they are classified as homogeneous and non-homogeneous. White patch begins as a mild or a thin leukoplakia and as many as 2/3 of such lesions slowly extend laterally, become thicker, and acquire a distinctly white appearance. The affected mucosa may become leathery to palpation, and the fissures may deepen and become more numerous. This stage, the lesion is called homogeneous or thick leukoplakia. Homogeneous leukoplakia is a completely whitish lesion and is divided into 4 types. Flat, which has a smooth surface; corrugated appearance, which appears like a beach at the ebbing tide; pumous, which represents as a pattern of fine lines; wrinkled, will have dry, cracked mud surface appearance. The next, the non-homogeneous leukoplakias, are also into 4 types: the nodular and the speckled, which is characterized by white specks or nodules with surface irregularity on erythematous base; the verrucous, which is slow growing with sharp, blunt papillary projections above the mucosal surface that may be heavily keratinized. The third, the ulcerated, where the lesions exhibit a red area at the periphery of which white patches are present. Erythroleukoplakia, where leukoplakia is present in association with erythroplakia. This is an image of homogeneous leukoplakia, which refers to a usually well-defined white patch, localized or extensive, that is slightly elevated and that has a fissure, wrinkled or corrugated surface. These are images showing nodular or speckled leukoplakia, which is represented as nodules; the verrucous leukoplakia, where oral leukoplakias are represented as papillary projections; a special high-risk form of leukoplakia, which is a proliferative verrucous leukoplakia, which is characterized by the development of multiple keratotic plaques with roughened surface projections. Moving on to the histopathological features, microscopically, leukoplakia is characterized by a thickened keratin layer of the surface epithelium, which is called as hyperkeratosis, with or without thickened spinous layer, which is called acanthosis. Some leukoplakias demonstrate surface hyperkeratosis but show atrophy or thinning of the underlying epithelium. Let's move on to the staging of leukoplakia. Staging is based on the various aspects like the size, the clinical aspect, pathological features, and the site of lesion. Based on the size, which is denoted by L, L1 represents size which is less than 2 centimeters, L2 is the size range between 2 to 4 centimeters, L3 with the size more than 4 centimeters, and Lx when it is not specified. Based on the clinical aspect, which is denoted by C, C1 represents homogeneous and C2 the non-homogeneous, where Cx is not specified. Pathological features, which is denoted by P, where P1 denotes no dysplasia, P2 mild dysplasia, P3 moderate dysplasia, P4 severe dysplasia, and Px not specified. According to the site of leukoplakia, S1 represents all sides excluding the floor of the mouth on the tongue, S2 represents the floor of the mouth and tongue, and S3 if it's not specified. Oral leukoplakia staging system, where stage 1 involves L1 and PO, stage 2 L2 PO, stage 3 L3 PO, or L1, L2 and P1. Stage 4 represents L3 and P1. Let's try to discuss the management of leukoplakia, where change is guided by the size of the lesion and the response is more conservative measure, which involves advice to the patient to stop on with the habits, particularly if they are associated with tobacco. Vitamin A could be given, 13-cis retinoic acid, and beta carotene, as well as vitamin C and E. If required, we can go in for complete excision of the lesion, which could be performed either using a scalpel, surgical knife excision with coverage of the resultant mucosal defect with split skin graft, excision by laser, and excision by cryosurgery. Let's discuss about lichen planus. Lichen planus is a relatively common chronic inflammatory dermatological disease that often affects the oral mucosa. It was named by a British physician, Erasmus Wilson, who first described it in the year 1869. The term planus is derived from the Latin word for flat. Moving on to the etiopathogenesis, the etiology of lichen planus is clearly not known, but during many years it has become evident that the immune system has a primary role in the development of this disease, which includes autoimmunity and immunodeficiency. Sometimes the psychological factor, mainly stress, is also thought to be associated with lichen planus. Vitamin deficiency and genetics can also cause lichen planus. It is thought to be associated with hepatitis C infection too. Let's move on to the clinical features. Most patients with lichen planus are middle-aged adults. It is rare for children to be affected. Women predominate in most series of cases, usually in the ratio of 3:2 over men. Oral lichen planus may contain both red and white element and provide, together with different textures, the basis for the clinical classification of this disorder. The skin lesion of lichen planus has been classically described as purple, pleuritic, polygonal, and papule. These usually affect the flexor surfaces of the extremities and other mucous membrane, usually associated with symptoms of intense pruritus. Essentially, there are two forms of oral lesions: the reticular variant, where the linear, hypertrophic, and plaque-like forms; the erosive variants, which includes the atrophic, ulcerative, and the bullous forms. Oral lichen planus is also classified into these 6 types. 1. The reticular, where the reticular form of oral lichen planus is characterized by fine white lines or striae. The papillar type of oral lichen planus is usually presented in the initial phases of the disease. It is clinically characterized by small white dots, which in most occasions intermingle to form reticular forms. Plaque type of oral lichen planus shows a homogeneous, well-demarcated white plaque that occurs in conjunction with striae. The plaque type lesions may clinically be very similar to homogeneous oral leukoplakia. The bullous form is very unusual but may appear as bullous structures surrounded by reticular network. The erythematous form of oral lichen planus is characterized by the homogeneous red area, but this type of oral lichen planus is represented in the buccal mucosa or in the palate. Striae are frequently seen in the periphery of the lesion. The ulcerative type is the most disabling form of oral lichen planus, and clinically the fibrin-coated ulcers are surrounded by an erythematous zone with white striae in the periphery. Let's discuss the clinical features of reticular lichen planus, where the reticular lichen planus is much more common than the erosive form, and it causes no symptoms and involves the posterior buccal mucosa bilaterally. Reticular lichen planus is named because of its characteristic pattern of interlacing white lines, which is referred to as the Wickham striae. However, the white lesion may sometimes appear as papules. These lesions are not always static but wax and wane over weeks or months. The erosive oral lichen planus is the second most common type, and it's represented as a mix of erythematous and ulcerated areas, which is surrounded by finely radiating keratotic striae, which may be symptomatic. The periphery of the atrophic region is usually bordered by fine, white radiating striae. Sometimes the atrophy and the ulcerations are confined to the gingival mucosa, producing the reaction pattern called the desquamative gingivitis. Let's move on to the histopathological features, where there are liquefaction of the basal cell layer, apoptosis of the keratinocytes, focal area of hyperkeratinized epithelium, which gives rise to the clinically apparent Wickham striae. There is atrophy of the epithelium, where the retipegs may be shortened and pointed. The thickness of the spinous layer can also vary. The retipegs are classically have a pointed sawtooth shape. The syndromes associated with lichen planus are Greenspan syndrome, which is associated with lichen planus, diabetes mellitus, and vascular hypertension. There's another syndrome also associated, which is called the Graham-Little syndrome, associated with alopecia, which occurs in most patients of lichen planus, and it's termed as lichen planus planopilaris. Many a times, nail changes are also present, which appears as longitudinal ridging and grooving, which may be seen. Management of oral lichen planus includes topical steroids, which are preferably used as a mouth rinse or a gel. Intralesional steroids could be used. Vitamin A, which could be used as an analog. Cyclosporins, tacrolimus, and PUA therapy could also be given. Let's discuss about candidiasis. Infections with yeast-like fungal organism, Candida albicans, is termed candidiasis. Oral candidiasis is the most prevalent opportunistic oral mycotic infection that develops in the presence of one or several predisposing conditions. Other species, which include Candida tropicalis and Candida glabrata, comprise together over 80% of the species isolated from human Candida infections. To invade the mucosal lining, the microorganisms must adhere to the epithelial surface. Therefore, the candidal strains with better adhesion potential are more virulent than the strains with poor adhesion ability. The yeast penetration of the epithelial cells is facilitated by the production of the lipases. And for the yeast to remain within the epithelium, they must overcome constant desquamation of the surface epithelial cells. There are various predisposing factors which are broadly divided into local and general factors. The local factors include denture wearing, smoking, inhalation steroids, topical steroids, hyperkeratosis, imbalance of the oral microflora, the quality and the quantity of the saliva. And the general factors include immunosuppressive diseases, impaired health diseases, immunosuppressive drugs, chemotherapy, and sometimes endocrine disorders. Now let's try to understand the classification of candidiasis, which is basically classified into primary and secondary. The primary is further classified as acute, chronic, and Candida associated. In acute, we have acute pseudomembranous and acute erythematous. In chronic, we have pseudomembranous, erythematous, plaque-like, and nodular. In Candida associated, we have denture stomatitis, angular cheilitis, and median rhomboid glossitis. The secondary candidiasis includes familial chronic mucocutaneous, diffuse chronic mucocutaneous, candidiasis endocrinopathy syndrome, familial mucocutaneous, severe combined immunodeficiency, Daigeorgi syndrome, chronic granulomatous diseases, and acquired immunodeficiency syndrome. Let's discuss the clinical features of oral candidiasis. First, on the pseudomembranous candidiasis. The acute form of pseudomembranous candidiasis, also called as the oral thrush, is recognized as the classical candidal infection which predominantly affects patients taking antibiotics, immunosuppressant drugs, or having a disease that suppresses the immune system. The infection typically represents with loosely attached membranes comprising fungal organisms and cellular debris, which leaves an inflamed, sometimes bleeding area if the pseudomembrane is removed. It is also present as white plaques. Both acute and chronic forms appear the same, except that the chronic form may emerge as a result of human immunodeficiency virus. The erythematous form of candidiasis was previously referred to as an atropic oral candidiasis or antibiotic sore mouth. The erythematous surface may not just reflect atrophy but can be because of increased vascularization. The infection is predominantly seen in the palate and the dorsum of the tongue of patients who are using inhalation steroids. Other predisposing factors that can cause erythematous candidiasis are smoking and treatment with broad spectrum antibiotics. The acute and the chronic form present with identical clinical features. The lesion has a diffuse border which helps us distinguish it from erythroplakia. Next, the chronic plaque type and the nodular candidiasis was termed as candidal leukoplakia, was characterized by a white removable plaque which has the typical clinical presentation as that of oral leukoplakia. It has also got an association with the malignant transformation. Denture stomatitis. The denture protects the microorganisms from the physical influence such as the salivary flow, the common site being the denture-bearing palatal mucosa. Denture stomatitis is classified into three different types: Type 1, which is limited to the minor erythematocytes caused by trauma from the denture. Type 2, which affects the major part of the denture-covered mucosa. Type 3, in addition to type 1 and 2, it has a granular mucosa in the central part of the palate. Angular cheilitis presents as an infected fissures of the commissures of the mouth, which is often surrounded by erythema. This is co-infected with both Candida albicans and Staphylococcus aureus. Vitamin B12 deficiency, iron deficiencies, and loss of vertical dimension have also been associated with this disorder. Median rhomboid glossitis is clinically characterized by an erythematous lesion in the center of the posterior part of the dorsum of the tongue. As the name indicates, the lesion has an oval configuration of erythema resulting from the atrophy of the filiform papillae, and the surface may be lobulated. The lesion frequently shows a mixed bacterial and fungal microflora. Treatment for fungal infections, which usually includes antifungal regimens, will not always be successful unless the clinician addresses the predisposing factors that may cause recurrence. Local factors are often easy to identify but sometimes not possible to reduce or eradicate. The most commonly used antifungal drugs belong to the group of polyenes or azoles. Polyenes such as nystatin and amphotericin B are usually the first choice in treatment of primary oral candidiasis. Topical treatments with azoles in case of angular cheilitis. Systemic azoles are used in case of deeply seated candidiasis. Sometimes surgical excision is done in type 3 denture stomatitis. In case of denture wearer, reduction of predisposing factor should always be the first goal for the treatment of denture stomatitis as well as for other opportunistic infections. The denture hygiene has to be improved, and a recommendation not to use the denture while sleeping is to be given. As porosities in the denture can harbor microorganisms which may not be removed by physical cleaning, the denture should also be stored in antimicrobial solutions like alkaline peroxidase, alkaline hypochlorides, acids, disinfectants, and enzyme solutions which are used during the nights. Antifungal drugs that could be probably used are amphotericin B, nystatin, clotrimazole, meconazole, ketoconazole, fluconazole, itraconazole, which can also be used. Oral submucous fibrosis is defined as an insidious, morbid, crippling, chronic disease affecting any part of the oral cavity and sometimes pharynx. Although occasionally preceded by or are associated with vesicle formation, it is always associated with the juxtaepithelial inflammatory reaction followed by the fibroelastic changes of the lamina propria with epithelial atrophy leading to stiffness of the oral mucosa, causing trismus and inability to eat. It is a high-risk precancerous condition of the oral mucosa seen primarily in the Indian subcontinent and the Southeast Asia. Etiopathogenesis. Etiology of oral submucous fibrosis is basically due to chilies, which has capsaicin as the active ingredient. The slaked lime is used with betel nut for chewing, also causes oral submucous fibrosis. The areca nut chewing habit, which contains alkaloids, of which arecoline seems to be primarily the etiological factor. The arecoline also has the capacity to modulate the matrix metalloproteinase, lysyl oxidases, and collagenases, all affecting the metabolism of collagen, which leads to an increased fibrosis. Let's discuss the pathogenesis of oral submucous fibrosis. The habit of chewing betel nut is going to cause an impact in the pathogenesis of oral submucous fibrosis. It is going to cause constant irritation. It is also going to cause the activation of the T cells, which leads to increased production of collagen formation and decrease in the collagen degradation, which leads to the formation of fibrosis. This is the pathogenesis of oral submucous fibrosis. Let's discuss the clinical features of oral submucous fibrosis. The first signs of oral submucous fibrosis are erythematous lesions, sometimes in conjunction with petechiae, pigmentations, and vesicles. These initial lesions are followed by a pallor mucosa, which may comprise of white marbling. The most predominant clinical characteristics is the palpable fibrotic bands, which is located beneath an atrophic epithelium. Increased fibrosis eventually leads to the loss of resilience, which interferes with the speech, tongue mobility, and decreased ability to open the mouth. It affects both the sexes between 20 to 40 years of age, and the most frequent location is the buccal mucosa and the retromolar areas. It commonly involves the soft palate, uvula, tongue, and the labial mucosa. When the tongue is involved, it becomes rather immobile, is frequently diminished in size, and may be devoid of papillae. Submucosal fibrous bands are palpable on the buccal mucosa, soft palate, and labial mucosa of the fully developed cases. Involvement may also extend beyond the oral cavity to involve the oropharynx and upper esophagus. Clinical stages of oral submucous fibrosis. According to Pinberg in the year 1989, OSMF is clinically divided into 3 stages. Stage 1, which is associated with stomatitis, erythematous mucosa, vesicles, ulcers, pigmentation, and mucosal petechiae. Stage 2, early lesions demonstrate blanching of the oral mucosa. Older lesions include vertical and circular palpable fibrous bands, malted marble-like appearance of the mucosa. Stage 3, sequelae of oral submucous fibrosis are as follows. Leukoplakia is a precancerous and is found in more than 25% of individuals with oral submucous fibrosis. Speech and hearing deficits may also occur because of involvement of the tongue and the eustachian tubes. The management of oral submucous fibrosis includes elimination of the habit, nutritional support, some immunomodulatory drugs like glucocorticoids, which helps in suppressing the inflammatory process and thereby reduce the collagen production. Physiotherapy may be used for forceful mouth opening, and heat therapy could also be done. Local drug delivery by local injection of corticosteroids to break down the intercellular cement substances. Combination therapy where placental extracts like hyaluronidase could also be used. We can also go in for surgical therapy by removing the fibrotic bands. Thus, a plethora of treatment strategies have been tried, such as the topical and the systemic steroids, along with the supplements of vitamin and nutrients, which leads to repeated dilatation with the physical devices and surgery. And to summarize, we have tried to understand the reasons why lesions appear white, the classifications of the white lesions, and trying to understand certain important diseases under the classification. Thank you.